A very good afternoon. Today's topic for discussion will be infective endocarditis. Infective endocarditis is the infection of the endocardium of the heart. This is caused by microbial infection of a heart valve or the endocardium or the inner lining of the blood vessels. Characteristic lesion of infective endocarditis are the vegetations, which are a mass of platelet, fibrin, microcolonies of microorganisms, and there are scanty inflammatory cells also. Both the native as well as the prosthetic valves can be affected with the infection. The most common causes of infective endocarditis are streptococci and staphylococci, while many other organisms also can be involved in particular conditions. This is a diagrammatic representation where we can see the greenish vegetations over the mitral valve. Here also we can see the destruction of the mitral valve. There are fibrin deposits, and this is a case of endocarditis because of Haemophilus parainfluenza bacteria infection. The prevalence and risk factor of infective endocarditis. In general population, the incidence has been estimated between 2 to 6 cases per 100,000. The incidence of infective endocarditis is very low in young patients, but as the age increases, the incidence also increases dramatically. And the peak incidence is seen between 70 to 80 years of age. The incidence also increases when there is history of rheumatic valvulitis, there is mitral valve prolapse or aortic sclerosis, or in those patients with bicuspid aortic valvular heart disease. In addition, the prosthetic valvular heart disease accounts for about 1/3 of all the cases of endocarditis, and it occurs in 1 to 3% of the patients after valvular heart surgery. The etiological organisms are mostly streptococci and staphylococci, and Staphylococcus aureus is the single most common cause of infective endocarditis, which accounts for nearly 40% of all the patients with the disease. Infective endocarditis is more often seen on the left side of the heart, that is involving the mitral or aortic wall. In about 20% of cases, there is right-sided involvement, that is the tricuspid or pulmonary valve involvement. IV drug abusers, they have a much higher incidence of right-sided endocarditis. Around 30 to 70% of these patients have endocarditis involving the right chamber of the heart. Etiologic agents in infants and children. Here the most common is staphylococci, alpha hemolytic streptococci, and second most common is Staphylococcus aureus, while in adults we have seen that Staph aureus was the most common. Gram-negative bacteria also can cause, and fungal infection also can cause infective endocarditis in children, but they are rare. Candida and other fungal infections can be there, but they are as such rare, and the most common are streptococcal and staphylococcal infective endocarditis. Rare causes, rare organisms causing endocarditis are Brucella, Coxiella, Bartonella, Chlamydia also can cause, Mycoplasma and Legionella. These can rarely involve the endocardium and cause infective endocarditis. Risk factor of infective endocarditis in various cardiac lesions. In patients with prostatic heart valves, patient with previous history of infective endocarditis, patient with tetralogy of Fallot, PDA, AR, MR, VSD, these patients are at high risk of developing endocarditis. While MVP with MR or degenerative valvular disease in elderly patient, tricuspid regurgitations, tricuspid stenosis, pure mitral stenosis, these have a moderate risk. And patient in which there is no MR but MVP is there or isolated ASD is there, in these patients there is a low risk of developing infective endocarditis. Endocarditis can present in two ways, acute or subacute, depending on the onset and the progression. Mainly, acute is caused by the pathogenic organisms and involves the native valves also, while subacute is usually seen in those patients with already diseased heart. So, acute infective endocarditis, we see that the onset from bacteremia is within 2 weeks and the progression is over days to weeks. The organisms are very virulent ones like Staph aureus, and the structural heart diseases can be absent here. While in subacute endocarditis, the onset is within months and the progression also is over weeks to months. The organisms are less virulent, for example, Streptococcus viridans, and usually there is a presence of structural heart disease already in these patients. Coming to the clinical features, the clinical manifestations of infective endocarditis can be grouped under 4 headings: constitutional symptoms, symptoms because of the particular type of cardiac involvement, symptoms because of embolic phenomena, and immunological manifestations, for example, Osler's node, Janeway's lesion, petechiae, purpura, and rod spots. Coming to constitutional features, these are attributed to the cytokine activation, and patient presents with anorexia, fatigue, there can be night sweats, and a feeling of unwell. Then there can be aches, pains, arthralgias, backaches are very common. Fever is almost always present in infective endocarditis. There is no particular pattern of the fever though, but recurrent chills at onset, they favor a bacteremic illness. Temperature usually varies between 100 degree to 103 degree Fahrenheit. Sometimes the fever may not be conspicuous, especially in patients which are frail, elderly, renal failure patients, or immunocompromised patients. These patients may not present with history of fever. Symptoms because of cardiac involvement. There is usually a presence of heart murmur in minority of the patients with cardiac involvement, but sometimes the murmur can be absent, especially in right-sided endocarditis, can be faint or even absent. Presence of changing murmurs or a new murmur, this can occur with valvular destruction and is a very characteristic finding in infective endocarditis. It can also be because of the caudal rupture, paravalvular leaks, or because of fistula formation. There can be congestive heart failure, and this is the commonest cause of death in patients of infective endocarditis. Embolism. Embolism, these vegetations, because of them, they can be embolized, and they can be clinically silent and only detected during autopsy. In about 60% they are detected in autopsy. Any organ can be involved by the embolism of the vegetations, but brain, spleen, kidney, bowels, limbs, or lungs. Lungs in case of right-sided, these are the organs predominantly involved in case of because of the embolic phenomena. Coming to the immunological manifestations, infective endocarditis results in intense humoral and cellular immune stimulation. The peripheral stigmata of IE are supposed to result from immune complex depositions, though septic embolism also can account for these. First is Osler's node. These are seen as typically 2 to 15 millimeter T-shaped painful reddish nodules seen in the pulp of fingers and toes in cases of classical infective endocarditis. Then Janeway's lesion. These are flat macular erythematous non-painful lesions, especially seen in palms and sole, and they are often seen in cases of Staphylococcus infective endocarditis, and the bacteria can be isolated from these lesions. Petechiae and purpura can be seen. Rod spots. Rod spots are retinal hemorrhages in which the center is white. So retinal hemorrhages with white centers are seen, and these are called rod spots. Lab features, clinical and lab features are, to summarize, they can be fever, which is a very common manifestation, and it is present in almost about 80 to 90% of patients. Then there can be history of chills, fever with chills and sweating in 40 to 75% of patients. Constitutional symptoms like anorexia, weight loss, malaise, they can be present in 25 to 50% of the patient. 15 to 30% have myalgias, arthralgias, back pain. Heart murmur is present in about 80 to 85% of the patients, and a new appearance of a new murmur or change in murmur or worsening of the murmur, especially the regurgitant murmur, is seen in 20 to 50% of the patients. Features attributing to arterial emboli, they can be seen in 20 to 50% patients. Splenomegaly can be there in 15 to 50% patients. Clubbing also can be seen in 10 to 20% patients. There can be neurological manifestations in 20 to 40% patients. Peripheral manifestations, generally the immunological manifestations like Osler's node and subungual hemorrhage, Scheinway lesions, etc., are seen in 2 to 15% of the patients. Petechiae are quite common, they are seen in about 10 to 40% of the patients. Coming to laboratory manifestations, there is anemia in 70 to 90% of the patient. There can be leukocytosis also. Microscopic hematuria can be seen in around 50% of the patients. The ESR will be typically raised mostly in most of the patients, around 60 to 90% patients. And CRP is almost always raised. Rheumatic factor can be there in 50% of the patient, positive rheumatic factor. Circulating immune complexes, they are also seen in large number of patients, 65 to even 100% patients they can be seen. And decreased serum complement level can be seen in 5 to 40% of the patients. Coming to the investigations, as we have earlier discussed, the lab features, investigations, hematological parameters will show a normocytic, normochromic anemia. Leukocytosis is not common but can be seen. ESR is very useful but it is not very specific. CRP can be tested. This is always in almost 90% of the patient that is increased. Serum ferritin, which is an acute phase reactant that can be elevated early in the course. Urinary examination, there can be microscopic hematuria. Gross hematuria suggests the presence of renal infarction. Then there can be proteinuria, then can be presence of CAS in the urine. Blood culture, this is the gold standard in which the organisms can be grown and culture sensitivity can be done. Echocardiography, this is the cornerstone of the diagnosis, and this has revolutionized the management of infective endocarditis. Presence of vegetations, new onset valve regurgitations, annular abscess or valve dehiscence, they are all can be seen on echocardiography and they are diagnostic of infective endocarditis. Transesophageal echocardiography is preferred in those cases which on transthoracic are doubtful. To require to monitor the course of illness, it is very important and is extremely useful for taking the therapeutic decisions also, because it gives the hemodynamic information and an idea about the therapeutic response also to various management regimes. For diagnosis, the modified Duke criteria, which is used, in which there are major and minor criteria. The major criteria are positive blood culture for typical microorganisms from 2 separate blood cultures. So, Streptococcus viridans or Streptococcus gyrolyticus, Hatchick group of organisms, Staph aureus, or community acquired enterococci in absence of a primary focus. Or there can be in the blood culture, there can be persistently positive blood culture defined as recovery of a microorganism consistent with infective endocarditis from the blood cultures drawn more than 12 hours apart, or all of the 3 or majority of more than or equal to 4 separate blood cultures with first and last drawn at least 1 hour apart, or where single positive blood culture is there for Coxiella burnetii or phase 1 IgG antibody titer is more than 1:800. Second is evidence of endocardial environment. Positive echocardiogram is also a major criteria. There can be oscillative intracardiac mass on the valves or supporting structures, or it can be in the path of regurgitant jets or in the implanted materials in absence of any alternative anatomic explanation. Or there can be abscesses seen in echo, new or partial dehiscence of prosthetic valve can be seen. So these are the major criteria. Minor criteria are predisposing heart conditions are if there, or there is history of IV drug use, fever more than 38 degrees centigrade, that is more than 100.4 degree Fahrenheit, vascular phenomena like major arterial emboli or septic pulmonary infarcts, presence of myocardic aneurysms or episodes of intracranial hemorrhage, conjunctival hemorrhage, or presence of Janeway lesions. These are minor criteria. Then immunologic phenomena like glomerulonephritis, Osler's nodes, or presence of rod spots or rheumatic factor, these are also comes in the minor criteria. Microbiologic evidence. Positive blood culture is there, but it is not meeting major criteria as we have discussed earlier. Or serologic evidence of active infection with an organism consistent with infective endocarditis. So definite endocarditis is defined by documentation of two major criteria, or one major criteria and three minor criteria, or if there are five minor criteria are present, then we diagnose the patient as having infective endocarditis. Differential diagnosis. The most difficult differential diagnosis is in non-RHD patients, because this involves the consideration of rheumatic activity versus the presence of infective endocarditis, because both can cause fever, both can have raised ESR, there can be arthralgia, there can be worsening heart failure, and even sometimes vegetations can be seen. In rheumatic fever though, the symmetrical small vegetations are different. The ASO titer is raised, there may be presence of nodules, and fever is not long lasting. So these can help pointing toward the presence of rheumatic activity. Positive blood culture. Positive blood culture is the mainstay for diagnosis. 3 separate tests of blood culture are done, each from a separate venipuncture site, and they should be obtained over 24 hours. Minimum amount of blood that should be used is 10 ml, and the first 2 sets of culture are positive in 90%, more than 90% of the cases. The culture should be incubated in both aerobic and anaerobic atmospheres to detect organisms such as bacteroids or Clostridium species.